So today, what we'll be talking about is lumbar radiofrequency ablation. So very common technique that we're doing almost every day in our OBL, ESCs, etc. So we're going to be talking about two type of ablation technique that provide larger ablation zone. So the first is the Trident that is fairly new to the U.S. market. I've been using it for quite a while in Canada. It is an interesting technology because it does provide to have a larger ablation zone. So we're talking about an ablation size of close to 9 by 10 millimeters. There are some tines that can open up while you rotate the proximal hub, and those three different tines will provide a larger ablation zone. So very interesting technology. And the second type of probe that we'll be using today is the COOLIEF probe. Let's see if we can just zoom on that probe here. That has an internal cooling system. So rather than ablating at 80 degrees Celsius, we'll be ablating at a lower temperature close to the probe tissue interface. So we're staying in the 60 degrees range close to the probe. That will allow also a larger ablation zone. So those are two different probes that we use commonly in our practice for various type of ablation. Interestingly, if we take a look at radiofrequency ablation overall, those two, although they use radiofrequency technology, so oscillation of ions that are close to the probe, there'll be different technique, different technology that will allow different ablation size. So first, if we take a look as an example here with the Avanos COOLIEF technology. So normally we're starting about at 60 degrees around the probe. And this is temperature, this is distance. You'll see that the ablation, well, the temperature will increase with distance from the probe, versus if we take a typical radiofrequency probe, you're going to see the peak temperature that is close to 80 degrees, close to the tip of the ablation probe, that will decrease with distance from the probe. So that and this is an important concept, because normally with typical radiofrequency probes, you will have, if you're very precisely located on the nerve, you're going to have excellent outcome. If for whatever reason, it is more difficult to position the probe close to the nerve, or you have more anatomical variability, using a large ablation zone, just like the COOLIEF system, may be useful. So right now we're going to review some basic, very reliable techniques to perform the lumbar radiofrequency ablation. So we can start right now. So if we want to position, I think I have a lumbar spines here. So the goal of the procedure is to ablate the dorsal primary ramus of the exiting spinal nerve. So we want to position more frequently than not the probe parallel to that nerve. So actually right here, right here, right here. So we'll be located right under or very closely to a ligament called the mammillary accessory ligament, and perform the ablation. The advantage with the larger ablation zone, again, either a Trident or with COOLIEF, is that you can use because we obtain a more spherical ablation, you don't need to be as parallel to this nerve, and you can have a little bit more flexibility in your approach to the junction between the superior articular process and the transverse process. So we'll be demonstrating that at a various level, and we'll go from there. Okay, so picture here. Perfect, picture here, picture. Perfect. So right now we're aiming for the dorsal primary ramus of L5. So we'll go down. Picture here. So again, you see the superior articular process of S1, and then you have a small groove there that you can position the needle in position. Picture. Yeah, that looks pretty well positioned. We can position also the other one at the same time. Picture here, picture here.
As he goes down and advances to the junction between the superior articular process and the sacral ala, the nerve is located a little bit more up on the superior articular process at L5S1 as compared with the junction between the SAP and the TP for the rest of the lumbar spine. And the ablation zones for these, the standard RF ablation zone is about 180 to 200 cubic millimeters. For a protruding RF, it's about 270 to 300 cubic millimeters. And so for cool RF and the multi-tined units, it's about right around 600 cubic millimeters. So the purpose of having cool RF, this is circulating water through the distal tip of the needle, is to propagate the heat, to cause less charring. So the heat propagation is 80 to 85 degrees Celsius distal to the needle. And that's the purpose of making the zone bigger. And the purpose of the multi-tines is to have more tines to cover greater cross-sectional imaging.
Yep. So right now we're gonna go just verify our depth, making sure that we are adequately positioned.
So those in the position of the oblique look perfect. Junction between the transverse process and the superior articular process, and then it was a little bit more up the transverse process on the lumbosacral junction.
Down a little bit. As far down. Yeah, if you can bring the table up, we can show. Perfect. If you can cone a little bit more, yeah, perfect. That looks pretty good. We'll just advance a little bit more. This one. So if you can advance it, maybe cone, just to get rid of some of the air. I'll be able to demonstrate well the depth there. So that looks pretty good. Maybe we'll advance just a little bit more this one. So again, these are needles that deliver larger ablation zone and more energy delivery ventrally. So there's about 45% more energy delivery ventrally than typical radiofrequency ablation. So that's something also to consider. So testing is very important. So testing at 2 volt, 2 hertz, making sure that we're at a safe distance from the exiting ventral route. And before proceeding with the ablation for 90 seconds, in that case, with the tridents. So in terms of positioning, this looks great. So we could do the testing, and then there's also side ports that are quite handy here that allows local anesthetic prior to proceeding with the ablation after the testing. And when we're all ready to go, we can open up, maybe for the first, if you can just give me some live here. It may be difficult to see, okay, no. But the trident system is open, so you can see actually those three separate tines that will be providing this large ablation zone. So for lumbar radiofrequency ablation, quite a straightforward technique. again, something that we do very frequently in our office or in the ASCs, and very important for our patient in interventional pain management.
That's great. So, Dr. Clerk, if you guys could make the switch now to go ahead and rotate over to do the hip from the supine position. So, a couple of additional points on this. You mentioned sensory motor testing. Some people test, some people don't. I don't find the real need. I haven't sensory and motor tested for quite some time. I don't think Dr. Chandra, my current fellow, Matt, raise your hand so everybody can identify him. You can pass your condolences, feel sorry for him later. Just give him a pat on the back. We don't sensory motor test, but if we did, it would be up to 1 and 3 volts. Dr. Clerk tests at 2 and 2. You can test just to make sure there's no motor action there. When you do ablation, you will see a multifidus thump. It will have a rhythmic thump, and that's where you know you're in the right location if you place the needles here. If you place the needles closer to the joint, just lateral to the joint, there is a multifidus sparing technique that you can put the needles just lateral to the joint. So it's a little bit superior and a little bit medial to the target between the junction between the SAP and the transverse process. So that's a multifidus sparing technique, and that's a known thing. Some people are critical about repeated RFAs and about the adverse effect because it will denervate the multifidus.
Right side's fine.
And the multifidus is an important to function. There are manuscripts that state the more the patient has multifidus atrophy, the more likely they are to have back pain. There are also restorative therapies. So Mainstay makes restorative treatment for multifidus stimulation, and it's done so by stimulating the medial branch of the dorsal ramus to stimulate the multifidus to cause decrease in back pain. So having said that, there is some controversy about that, and it's not linearly related. So if you can use a multifidus sparing technique and you're inclined, there is a technique available. We inject a little steroid to prevent post-denervation neuritis, and so this happens at about a rate of 5% statistically. I think we've seen one case of post-denervation neuritis in the past 5 years, so it really helps cut down on that. Dr. Clerk, just let us know when you guys are ready, and we'll kick it off with hip nerve RFA.
Perfect. So we were talking about the advantage of having a larger ablation zone. So the hip is a good example also why using those larger ablations. There's some anatomical variability into the innervation of the hip. So there's 2 different nerves that can be ablated for decreasing the pain related to the hip. So first, superiorly, picture here, and picture. It's about, picture here, just about at the roof of the acetabula, about 12 o'clock position. There's the articular branch of the femoral nerve, and then picture here. Yeah, we'll just recenter on the hip a little bit. Perfect. Picture here. And here there's the articular branch of the obturator nerve. So those 2 anatomical regions can be ablated and ablated safely. Why do we do that? Well, there's still a certain percentage of patients that even after total hip replacement or arthroplasty that will have pain, so about 1 to 2%. There's also, in my practice, I'm seeing frequently patients in obesity clinic that wants to lose weight but have hip pain. And for those patients, basically, often they have limited options. So doing a hip ablation can definitively decrease that pain and while they proceed with their weight loss journey. Also, some patients that are not good surgical candidates. So all those reasons, this is a procedure really that's gaining in popularity. So we'll get started with the positioning. So there's some real estate that needs to be discussed here. There's also the femoral nerve, femoral artery that normally passes about here. about midway to 30% medial of the femoral head. So that's something that you want to stay away from in a patient. You can palpate the femoral artery. You can use ultrasound also just to make sure that you're at a safe distance from this structure. So we'll first start a picture here.
As you go through that, Dr. Clerk, I'm going to talk about the femoral artery. The femoral artery location that he just showed, it's very consistent. It's consistent with everybody. Thin, morbidly obese, it's consistent with everybody. And so my initial background was as an interventional radiologist. I used to do angiography, and we would do this, go all the way down. We would put a 17-gauge needle all the way down to find the femoral artery, and it is always located in the medial 20% of the femoral head. It's there, it's consistent, and using that, you can bank on this, using that as a landmark as to where not to go. So it's about an 8 millimeter to centimeter artery located in the medial 20% of the femoral head, and so and it's located fairly superficial. So you can use depth and location, just not hit the femoral artery. And there's really, I haven't seen a case of that in forever. So it's a very safe procedure, even with using the obturator branches, capsular branches overlying the ischium, just inferior to the joint right there, just lateral to the teardrop, just inferior to the femoral head. You'll see where he places these, but this is a exceedingly safe procedure.
Yeah, so we're well positioned here for the femoral articular branch. We can even be just a slightly more, see if I'll picture again, so something like that. So that will be the first ablation site. So you want to start fairly lateral also to have quite a shallow approach up to this anatomical region. Again, for this nerve, just like prior to any ablation, we would want to be doing the motor testing, making sure we're from a safe distance from the femoral nerve, and prior to proceeding with the ablation. I didn't mention the ablation for the Coolleaf system is slightly longer than with the conventional RF. So it's 2 minutes and 30 seconds. So normally we would be positioning 2 needles prior to proceeding with the ablation. So let's start also with the second ablation site. Picture here. Picture here. Okay, so we want to start pretty much at the ischion or most inferior portion of the inferior pubic ramus, so about here at the skin, and then proceed with local anesthetic prior. Picture here. Picture here. A little bit too medial.
So he's aiming at the obturator capsular branches that we just talked about.
Perfect. So that looks pretty good for the first ablation. So you want to be here. I'll just picture again. Picture. You want to be pretty much midpoint between the incisura or the teardrop. That is, give me some life here. Some life. Yeah, so picture again. Picture. So right here you have the teardrop and the incisura. So midpoint between that anatomical landmark and the inferior portion of the femoral head, you want to be positioned. So this is where you're going to have most of the branch of the articular branch of the obturator nerve. So first ablation here. So we will be ready again testing. Ablation, we would ablate both sides at the same time. Normally I do 4 ablation total, so second ablation that I'll remove up. Okay, picture again. Picture. Yeah, so move up a little bit the ablation zone for the articular branch of the femoral nerve, and down a little bit the ablation for the obturator branches here. So 2 sets of 2 minutes and 30 seconds, and normally you are done for the hip.
Can we take a picture of the fluoro shot of the hip? So ablation zone. Okay.
Perfect.
Ablation zone across here.
Doug, was there any other comments you wanted to add on the hip?
Just showing the people here on the fluoro image the full ablation zones. Very well done, Dr. Clerk.
Perfect. Thank you.
Any questions? Yeah.
Is there a role for other views to get a better sense of depth?
It's bony landmarks, bony stops. And so he used the Cooley, which protrudes about 40% beyond the distal tip of the needle. The multi-tine is up against bone perpendicular because it has a very flat ablation zone. So in this, no need for depth, no need for lateral. And, like a cross table lateral and a hip is hard enough to see. You can barely see the femoral neck. That's really what you're looking for. But no need for depth. All bony backstops. Yes.
How do you avoid the joint there? How do you make sure that you're not going into the joint? Because it does look awful close with that option.
Yeah, you just have to make sure you're right below the capsule. And I'd encourage you the next few hips you inject, put a little bit of extra contrast in them. So to get a good idea about where exactly the hip capsule is. It's a huge swath of territory right over the femoral head and neck. You can't miss it when you inject a hip. But it doesn't often get boggy enough or capacious enough so where it dips down. But, if it does, so the gamesmanship of this, if you have somebody with very severe arthritis, that hip capsule can dip down. And if you're unsure about where it is, put some contrast in it. Yeah. Okay, we'll segue. Just one more question. Yeah.
Sorry, could you repeat what you were saying on the teardrop and the relevancy in terms of this procedure? Like if you're outside the teardrop, you want to hit the femoral artery.
So the femoral artery is located on the medial 20% of the femoral head, and it goes superior-medial to infralateral, and it's always located there. And so if you're at the teardrop, you are medial to that artery 100% of the time. So just you can use that as a landmark, and I kind of prefer the medial 20% of the femoral head to know. And next time, I assume you haven't done a lot of angiography, right?
Correct.
Yeah. So next time you look at arteries around the hip, just look at that femoral artery, and it has the same declination, it has the same angle, it has the same position over the medial 20% of the femoral head. So just, you take that, put it in the bank, and use this. If you do a lot of hip RF, it will make you want to look at the arterial supply just to feel better. And look, the bottom line is if you hit the artery, the femoral artery, and again, I haven't seen anybody hit the femoral artery, I don't think ever. If you hit it, there's a great solution. It's this. Put your finger on the artery and apply pressure. We used to do this manually for 20 times a day for angiography, and that artery will close up, and you don't have to plug it. You don't have to sew it. You just put pressure on it. It'll be just fine. So Peter Nora is going to talk to us about collaborations between interventional pain physicians and surgeons.